All right, so good morning, good evening, and good night to from everyone across the globe who's joining us for this edition of the In Conversation series from the EIOC Journal Club. My name is Shaheenah Dawood, and I'm a consultant medical oncologist coming to you all the way from the United Arab Emirates. And today we're going to be talking about updates from ASCO GI. I think it was a very, very eventful ASCO GI in January. And I'm joined today by none other then Dr. Shitara coming to us all the way from Japan. Dr. Shitara, maybe you can introduce yourself.
Hello everyone, I'm Kohei Shitara. I'm a GI medical oncologist working at National Cancer Center Hospital East in Japan, and my specialty is upper GI cancer as well as early clinical development. Thank you for having me.
Thank you so much for being with us today. So I'm just going to share my slides. Now, like I said, there has been, I think an explosion of data this year. I think last year and this year, there's been an explosion of data from the realm of GI malignancies. And these are my disclosures. If anyone would like to network with me offline, please scan the QR code. So, Dr. Shitara, your specialty is upper GI, and you've done some of the seminal work for upper GI in terms of managing patients, specifically with gastric and gastroesophageal cancers. My question to you is, prior to the results of the trial that you presented at ASCO GI, which was the Illustra trial, how were you managing your patients with advanced gastric cancers whose tumors were both Claudin high positive as well as being PD-L1 positive? Because that's something that we face as community oncologists in the clinic on the ground.
Well, this is a very relevant question. Everyone don't know exact answer for that, but first, gastric cancer is a heterogeneous disease, so we need to test multiple biomarkers before first line, as everyone know, and these biomarkers include MSI, HER2, PD-L1 CPS, and now Claudin 18.2. In Japan, these four biomarkers is recommended to test simultaneously, and then we need to stratify patient to light treatment. And your question is particularly for patients with Claudin positive and CPS positive population.
Yes.
So again, there is no direct comparison between chemo-Zobi and chemo checkpoint inhibitor. So I always say like this, either choice is fine because we don't have a randomized study, but I personally believe chemo-Zobi is preferred option, particularly in patients with CPS less than 10. And chemo PD-1 is a preferred option, particularly for patients with CPS 10 or higher or MSI high population. The reason is particularly based on FDA ODAC meeting and combined analysis of 3 randomized studies to combine chemo and checkpoint inhibitor, including CheckMate 609, Keynote 859, and rational study. And FDA did very nice analysis after exclusion of MSI high patient. Hazard ratio in CPS less than 10 is quite, close to 1.0, almost like a 0.95 or 1.0. So these results suggest, chemo-Zobi is better. But again, there is no randomized study, so I think either option should be fine.
Absolutely. And before we go into the Illustra study, if I may ask you one more question, and this is just because practically in the clinic as community oncologists, this is what we're going to face. If you have a patient with a CPS of more than 10 and you give that patient chemo plus immunotherapy and that patient stayed on it for say 8 to 12 months, upon progression of disease, if that patient has a Claudin high tumor, how effective is Zolbi in that instance?
Well, this is a still open question. So we only have a Zobi monotherapy trial in data line. So no one report chemo or particularly paclitaxel or irinotecan with zolbetuximab combination. In also Zobi monotherapy showed very modest single agent activity. Response rate was less than 10 or 5% or less. And disease control rate around 40%, even in Claudin high expressing population. So the patient who progressed chemo checkpoint inhibitor and still maintain high Claudin expression, I think still usual second line like a paclitaxel plus ramucirumab is the best choice for this patient. But surely there is an ongoing trial to apply Claudin ADC agent. So if such trial is available or recruiting a patient in your region, I think enrollment in clinical trial is also a better choice.
Okay, so let's jump into the study that you presented at ASCO GI. I think everyone was looking forward to the Illustro study. This was a phase 2 study of patients with advanced gastric or gastroesophageal cancers with Claudin both moderate to high staining, and included all patients who are either PD-L1 negative or PD-L1 positive. Please correct me if I'm wrong. And you had two cohorts here, cohort A and cohort B, basically combining zolbetuximab, nivolumab plus FOLFOX, followed by a maintenance strategy. The primary endpoint was PFS. My question to you about the study design of Illustro is that it included both high and intermediate Claudin expression patients. Why did you include both cohorts of patients in Illustro?
Yeah, thank you for asking this important question. This is based on our hypothesis. Zolbetuximab may change tumor microenvironment, and a checkpoint inhibitor may enhance the activity of zolbetuximab. First, zolbetuximab already showed some change of tumor microenvironment as a monotherapy or chemotherapy plus zolbe combination. So our Japanese phase 1 study, we collected the tumor sample before and after zolbe, and it showed increased infiltration of Fc gamma positive CD8 cells and NK cell in line with mode of action, and it eventually increased infiltration of CD8 cells. So even in a non-immunogenic tumor like a PD-L1 negative population, we hope zolbetuximab may increase activity of PD-1 blockade. And also, as a PD-1 inhibitor, may enhance ADCC or CDC activity through activation of macrophage. We also consider checkpoint inhibitor may increase activity of zolbe even in Claudin intermediate expression. So that's why we enroll patients with both, yeah, as well as regardless of CPS status.
Okay, so these were the patient demographics. The median age was about 61 years. 86% of patients had tumors in their stomach, and you had a high Claudin expression was in 85% of patients with about 15% intermediate. 65% had a CPS of more than 1, and about 34% had a CPS of less than 1. The PFS in the whole cohort was 14.8 months. For zolbe FOLFOX6 modified as well as nivolumab. And when you looked at those patients, high and intermediate, you got a better PFS in your high at 18 months. Intermediate was at 6.7 months for progression-free survival. And when you looked at the CPS of more than 1, you had a median progression-free survival of 23.6, while CPS less than 1, it was 12.1. When you looked at the overall survival, it was still immature. It was not reached in the high Claudin group, at about 9.6 months in the intermediate Claudin group. And of course, 68% of patients had a response in the high Claudin group of patients with durable responses also observed in that high as well as intermediate group of patients. Again, you had the side effect profile was actually not too bad, and I'm going to ask you that question later on, Dr. Shitara, in terms of what you thought was the most important side effect that was seen with the addition of immunotherapy. But first, before we go into those results, which I thought were actually spectacular, in your opinion, what were the main limitations of the Illustrious trial? In your opinion, since it was your trial?
Well, this is a phase 2 study, single arm study without randomization, and we couldn't conclude the actual efficacy of this new combination, particularly compared with current standard of care like a chemozolbe or chemo plus checkpoint inhibitor. So that's why we need a larger phase 3 study.
Okay.
And another
Yeah,
limitation might be the patient characteristic. As you can introduce in the patient characteristic, around 70 to 80% patients were from Asia. Surely gastric cancer is a little bit prevalent or common in Asia. So this is in line with the actual nature of patient prevalence. But it is not easy to compare the actual historical data from global phase 3 studies. Sometimes it includes rest Asia. So this is also another limitation.
Okay. If I may ask, what were your thoughts on when you saw the results of the PFS and the OS data in those patients with the intermediate Claudin group? Were you underwhelmed by those results? Were you expecting higher, better PFSs, or were this is in line with what you were expecting?
Well, as mentioned, we initially expect better outcome even including low expressing population or PL1 negative or CPS less than 1 population. But the results shows a difference or separation of Kaplan-Meier curve according to these subgroup analysis. Although each subgroup are too small to conclude. But based on these results, ongoing phase 3 study enroll patients with high Claudin as well as a CPS1 or higher. So this is based on extensive discussion with us investigators as well as a sponsored company. But the data support such population might be best population to be treated by this combination.
This combination. Now, in the illustrative trial, are you planning to do any subgroup analysis looking at the different stratas for CPS scores, like more than 1, more than 5, more than 10, to see if there's a subgroup that's really benefiting from this triplet combination?
Well, same is true for this kind of question because of the very small sample size, some small subgroup. I believe we couldn't conclude anything for this very tiny subgroup. So eventually we can answer such CPS 1 to 5 or 5 to
Okay.
10 subgroup by ongoing phase 3 study.
Okay. And did you look at the data of, say, the intermediate Claudin group and the high PDL1 to just see if that was the
Sorry,
group that was benefiting?
I maybe I didn't see such data in detail.
Okay.
There's just some
Okay.
breakdown according to these biomarkers, but again, very small, very hard
Yeah,
to
I can
interpret it.
imagine.
Yeah,
The numbers were pretty tiny. This was a phase 2 study, but we always ask all these different questions to try and see or tease out those subgroups that may
yeah,
benefit the best.
sure, I can understand such question.
So,
But regarding your another question about
yes,
the response rate in
yes,
patients with high and
Claudin.
CPS1 or higher. Actually, this was included in upcoming manuscript, and it
Okay.
showed more than 70% response rate as
Wow.
expected.
Okay. Well, so that at least maybe a subgroup that we need to be thinking about more closely in going ahead in the future. Now, coming to the side effect profile. Now, Elastro appears to show a notably lower incidence of nausea and vomiting. And as you know, a lot of the community oncologists are very apprehensive about using Zolbi because of the significant nausea and vomiting that's associated with it. How do you explain for this compared to what we saw in Spotlight and Glow? Do you have insights into some of the
Well,
factors?
yeah, this is especially based on beta management, especially including multiple antiemetics like NK1 inhibitor, corticosteroid, 5-HT3, as well as olanzapine. And this is actually applied in almost all patients in an institution, and such kind of information or experience well informed in other investigators who participated in this study. And such recommendation is totally different in previous phase 3 trial where corticosteroid is not recommended based on preclinical concern to diminish activity of the rituximab with a reduced ADCC activity. This is only based on preclinical study, but as a result, we recently reported such subgroup analysis according to use of steroid or more detail of nausea and vomiting treatment course in ESMO Open Journal, and it showed patients who received corticosteroid showed better outcome or more benefit with rituximab because of the better safety profile or lower incidence of discontinuation. So again, this is particularly based on beta management, including more antiemetics as well as investigators' experience.
Okay. I can tell you for our patients here in Dubai, when we're giving them zolbetuximab, we do all the things that you've said that we should do. Plus, everyone gets olanzapine upfront, and it seems to be helping in terms of
Yeah.
the intense nausea and vomiting that you get early on. So
Mm.
this is the phase 3 trial, the Lucerna study, that is actually being planned and being conducted. My question here is why pembrolizumab? Because in Illustro it was nivolumab. Is there something different about the two immune checkpoint inhibitors, or this was just something that was pharma driven?
Yeah, actually, this is a firm-driven or based on strategic discussion between company. Actually, this might be somehow confidential, but previously, VMS already have a collaboration with other company who develop Claudin-targeted agents. So that's why they hesitate to collaborate this study. But Merck or Pembro companies are happy to join based on this concept. And I personally believe there's no difference between Nivo and Pembro, so either
Okay.
should be fine. And I'm happy to have this ongoing phase 3 trial.
All right. All right, so let's shift gears to our patients who have got HER2 positive disease. We've got the results of the Keynote 811 study that told us that in those patients with HER2 positive PD-L1 positive patients, if you give a combination of pembro, trastuzumab plus chemo in those patients with gastric or gastroesophageal cancers, this was the way to go in terms of an improvement in that overall survival group in terms of the endpoint. This year at ASCO GI, we saw the results of the Horizon study. This was using a drug called zanidatamab, which I cannot pronounce correctly, plus chemotherapy, plus minus immunotherapy with tilsilizumab as a first-line treatment in patients with HER2 positive, locally advanced, or unresectable metastatic GE tumors. Now, these patients were randomized to get either trastuzumab plus chemo or zanidatamab plus chemo or the triplet combination where you added the immune checkpoint inhibitor with tislelizumab, and they had dual primary endpoints of PFS as well as overall survival. When looking at the baseline demographics, again, median age was about 60 years. Half of these patients came from Asia. 95% of these patients had metastatic disease, with the majority having gastric cancers. And of course, in terms of PD-L1, more than about 60% of these patients had a PD-L1 of more than 1%, and the majority of these patients used CAPOX. Looking at the primary endpoint in terms of PFS, the triplet combination was better than the doublet combination of trastuzumab plus chemotherapy, with PFS improving from 8.1 months to 12.4 months. And when you looked at trastuzumab chemo versus Zani plus chemo, it again improved from 8.1 months to 12.4 months. When you looked at overall survival, the triplet was superior to the doublet, 19.2 months to 26.4 months. And the doublet again was inferior to the doublet of Zani plus chemo. It improved from 19.2 months to 24.4 months in terms of overall survival. So my question now to you, Dr. Shitara, is we have the Keynote study, and we now have the new Zani study for patients with HER2 positive gastric cancer. Where do we place it? And is immunotherapy really necessary? Because when I'm looking at the overall survival, I'm finding that it is not, I mean, it's not head to head in terms of Zani chemo or the triplet with immuno, but I find it's almost very similar. So what are your thoughts here?
Well, first, this is not a comparison with the Keynote 811 regimen,
Of
so
course.
we couldn't conclude this new regimen is better than Keynote 811 regimen. But so at least I think this could be one of the treatment option if receive regulatory approval. These two comparison clearly suggest Zani is better than Tras, although this is more toxic with more diarrhea. Maybe we can discuss this later. But I believe chemozani with Tisre or without Tisre could be treatment option, particularly for patients with fit situation. And maybe we can discuss more about PD-L1 biomarker status as well as the toxicities.
Okay. And I mean, should the trial have been designed with a control arm, like you said, it should have been the Keynote 811 control arm to actually show superiority. But what are your thoughts about the addition of immunotherapy, at least with this particular regimen? Because it seemed like
Yeah.
irrespective of these patients, yeah.
Um, in oh, sorry, sorry. The actually median PFS or OS is not largely different, as you mentioned, but
Yes.
looking at the tail of the PFS curve or OS curve, 18 months PFS rate or 2-year OS rate, nearly 8% or close to 10% better with TISREC combination. So immunotherapy may improve durability of response or survival. So that's why overall survival was only met at this interim analysis with triplet. So clearly, anti-PD-1 may improve at some degree with durability in selected patients. But at this stage, we don't know who are such patients. We
Okay.
should receive checkpoint inhibitor. Based on the safety profile, I personally think triplet is applicable to most patients. But if we can identify such patients who should receive checkpoint inhibitor by additional biomarker analysis, it should be interesting.
What about this the side effect profile of Zani? It seemed to have more associated diarrhea compared to what
Yeah,
we've seen in Keynote. So how would you
exactly.
how would you place that? Is it something we need to be thinking about and counseling our patients about?
Yeah, you should inform such toxicity to patient for appropriate management. But as already introduced during ASCO GI, this kind of diarrhea is usually relatively transient. Usually happen after 1 week in first cycle, and sometimes we need an interruption of capecitabine of chemotherapy. But after dose reduction of cytotoxic chemotherapy in second cycle, almost all my patients are doing fine. So
Okay.
interestingly, previous study or previous my experience showed Zani monotherapy is very feasible. The patient experiences diarrhea, but usually very mild, grade 1, 20 to
Okay.
30%. But interestingly, if we combine with one cytotoxic agent like capecitabine, this incidence of diarrhea increased by 20%. Then if we combine with oxaliplatin, now all grade diarrhea incidence is 80 to 90%, most patient experience. So interestingly, not only Zani, but also chemotherapy component also increases this kind of diarrhea. So we are not sure what is the actual mode of action, but I believe EGFR signal is also blocked because of the heterodimer shutdown with this zanidatamab. And
Okay.
HER2 and EGFR interaction should be important for in testing for physiologic function, and it may be impaired by this kind of combination, especially with the chemotherapy. But again, after dose reduction or some interruption, same is true for Zolvi combination. Usually first cycle is very, very important. But after that, most of my patients are doing fine. And as introduced during presentation, less than 10%, I believe nearly 5% patient discontinue Zani by toxicity. But otherwise, more than 90% patient can continue it.
Continue.
So we need to inform patient, but usually this is within manageable range.
All right, so now let's move into a slightly earlier stage where we're looking at the Neo Summit '01 trial. This was a perioperative study of looking at the PD-1 antibody toripalimab combined with chemotherapy versus chemotherapy alone in patients with locally advanced gastric cancer or gastroesophageal junctional tumors. The key eligibility criteria were these were patients who were treatment naive with a clinical T3 to T4A and node positive, of course, no metastatic disease, adenocarcinoma patients aged 18 to 75 years with a good performance status. These patients were randomized to get toripalimab plus chemo for 3 cycles or chemotherapy alone for 3 cycles. They would go on to receive go on to have surgery, and then, of course, post-operatively would have a similar regimen at that point in time. In terms of the event-free survival, you can see that there was an improvement in event-free survival when you added toripalimab to chemotherapy. The 3-year event-free survival improved from 56.2% to 74.7%, and a superior overall survival where it improved from 72% to 81.3%. You see a consistent EFS and OS benefit in those patients with MMR proficient disease, which is something we're always looking for, and a consistent EFS and OS benefit in the per protocol population as well. Now, I liked this slide that I saw at ASCO GI also, that's sort of putting it together with the Matterhorn Keynote 585 and the Dante study. And of course, now we have the Neo Summit 01, which is a phase 2, not like the phase 3 that we saw in Matterhorn. But what was impressing me was the hazard ratios that we're seeing here. The hazard ratios, in fact, for me, looked more impressive than what we've seen before, but would love to get your insights on that, Dr. Shitara. So if I could ask your view here, in view of Matterhorn, where does the Neo Summit actually fit? We also know that the chemo was different for Neo Summit compared to Matterhorn. So can we potentially substitute FLOT for FOLFOX, especially in those patients who can't tolerate or will not be able to tolerate FLOT?
Well, I think this is another study which clearly support use of PD-1 inhibitor at the perioperative setting for gastric and GI cancer. So this is a very good news for us as well as a patient. But as you mentioned, backbone chemotherapy is different, and this S1 plus oxaliplatin is very popular, especially in China and Japan. In Japan, not a few doctors prefer S1-based therapy, particularly for metastatic disease. And now S1 and oxaliplatin is investigated at the perioperative setting. So for investigator or for patients who are not fine to be treated by FLOT or who are not be familiar with using FLOT, I think this doublet chemotherapy is still option in this kind of patient. I personally use FLOT for more than 200 patients in an institution, and I don't believe this is an issue for us. And other study like FLOT4 or Japanese adjuvant study always show the importance of docetaxel. So to be honest, I'm not sure whether we can actually omit or remove docetaxel in this perioperative setting where we combine anti-PD-1 therapy. So this is our major limitation. But again, anti-PD-1 is clearly important at this stage for gastric and GI cancer.
Perfect. Do you think the IO therapies are interchangeable in this setting? This is like the multi-million-dollar question that everyone's asking now.
I personally believe yes. If this is not anti-PD-1 but CTLA-4 or other checkpoint, maybe we need confirmation. But this toripalimab, I couldn't pronounce it well, but this agent also showed a survival benefit at metastatic setting in gastric cancer or other types of tumors, and in direct comparison showed this agent is very similar to that of Nivo and Pembro. And in upcoming meeting, we also see another phase 3 study from China to combine this S1 oxaliplatin backbone with other anti-PD-1 therapy. This was already press release in the company's website, and this is this Neo Summit is phase 2, but upcoming study is phase 3, and this is again S1 and oxaliplatin backbone chemotherapy, and it already showed a positive outcome in EFS from the press release. So this multiple study clearly show oxaliplatin-based backbone with checkpoint inhibitor is effective for gastric and GI cancer.
So I really wanted to ask you this question because I have a patient that is very similar to this scenario where she has MMRD disease. So she's got MMR deficient disease. Her TMB is high. Clearly, this lady probably has Lynch, but we are testing for that. Does she really need FLOT? Can we get away with FOLFOX plus immunotherapy? And she asks the question, can I get away with not giving chemotherapy at all in that MMR deficient cohort of patients? What are your thoughts there?
Well, to be honest, this is not scientific, but maybe it's based on reimbursement. For example, in Japan, we can only use chemotherapy and a checkpoint inhibitor combination at first line, or a patient with borderline disease. We couldn't use anti-PD-1 monotherapy for any types of gastric and GG cancer, even with MSI high tumors. So I always combine with the checkpoint inhibitors and the chemotherapy. We can only use Nivo and EP combination for MSI high colorectal cancer. We cannot use Nivo EP for gastric cancer. So my choice in clinical practice is very easy. We can combine chemo and checkpoint inhibitors. And at this stage, we cannot combine with the FLOT because we are still waiting for FLOT plus durvalumab approval in Japan for locally advanced disease. So I always combine with a FOLFOX with a PD-1 inhibitor, even in patients with borderline MSI high disease. But in future, we should have such question. And I personally believe anti-PD-1 monotherapy is not enough for this gastric cancer compared with colorectal. Colorectal previous MSK study or others showed nice activity with anti-PD-1 monotherapy and high clinical complete response rate. But I believe gastric is a little bit different. And I think chemo and combination or Nivo-EP combination is better than anti-PD-1 monotherapy. So again, for your patient, I believe at least the chemotherapy combination is better if you don't have access to Nivo-EP combination.
So do you think in the early stage setting, like a Matterhorn type protocol, so a Matterhorn type patient profile or NeoSummit type patient profile, what if that patient has HER2 positive disease? I know we don't have the data, but do you think that chemo plus immuno is actually the best way to proceed in these patients? What do you think the future will hold for these HER2 positive patients?
So at this stage, I think chemo and the checkpoint inhibitor is a choice, but surely we want to apply chemotherapy regimen, zanidatamab combination or TDXD combination in future. And multiple studies are ongoing at this stage, and hopefully we have a more larger study as a global study to receive regulatory approval or achieve it.
Okay, so let's shift gears to the Critics 2 trial, which I thought was very interesting. This is a trial that took patients with gastric or gastroesophageal junction with resectable gastric cancers, randomizing them to get either chemo with DOC times 4 followed by surgery, or chemotherapy followed by chemorads followed by surgery, or just chemorads followed by surgery. Again, very interesting trial. These were stage 1B to stage 3C resectable gastric cancer patients, good performance status patients. You can see that 85% of these patients had stomach cancers and about 12% had GE junctional tumors. And what they essentially showed was that 55 patients were in the chemotherapy alone arm. You had about 42 patients who were in the chemorad arm, and the chemorad arm alone, it was 57 patients. In terms of a PCR in the chemo, and so in the chemorad arm, they had a PCR of 20% compared to 8% with chemo alone and 13% with chemoradiation therapy alone. In terms of event-free survival, I found this very interesting. The best event-free survival is actually coming from the DOC plus chemoradiation therapy arm, which also was translated into a strong trend in terms of the overall survival. Now, this is very different compared to what we saw in Top Gear, which also had a perioperative chemo, pre-op chemorad type protocol that they compared, and there was absolutely no difference in terms of the outcomes of these patients. And just looking at the differences between Top Gear and Critics 2, the type of chemotherapy was obviously different, where you're using a docetaxel type regimen in Critics 2, and the majority used an ECF type regimen in Top Gear. In terms of the concurrent chemo regimen, it was just 5-FU in Top Gear, while it was weekly carbotaxel in the Critics 2 arm. And the type of radiation in terms of required IMRT was not required in Top Gear, and it was required in terms of the critics too. So, Dr. Shitara, I think the use of radiation therapy in gastroesophageal cancers and gastric cancers has been the topic of discussion for the last couple of years, where at one point we said no radiation therapy, and now we're coming back to should we even consider radiation therapy in these patients? Where do the results of critics actually fit into clinical practice?
Well, this critics 2 is very interesting, but it's still very small phase 2 studies are not conclusive. And based on this result, we shouldn't change our clinical practice. We need more data to support this kind of strategy. And as you mentioned, there is another study which couldn't support chemoradiotherapy like Matterhorn as well as ESOPEC as well as
Top Gear.
Top Gear study. So to overcome these two phase 3 studies by only this one small study is very difficult. But still, there is some interest about incorporation of radiotherapy. First, there is an ongoing AIO study to combine float plus short course of radiation. So the phase 3 study is ongoing. This is a more straightforward trial because standard of care is float and incorporation of radiotherapy during the fraud. This is also interesting. But this study didn't include a checkpoint inhibitor. And now standard of care is fraud plus durvalumab in available countries. So we need to consider other study to answer this clinical question. And another role of radiotherapy may to use, particularly for organ preservation. And actually, I'm doing such a study to incorporate float plus checkpoint inhibitor with short course of radiation. And if patient achieve clinical response, as well as a ctDNA clearance with very high sensitive analysis, patient can be managed by organ preservation. So this is a small study, but study is ongoing.
I think that will be very interesting as we've tried to de-escalate surgery for across other tumors as well. So I think this will be very interesting. So let's shift gears to even going upper with pancreatic and cholangios. This was an interesting trial that looked at the efficacy of an agent in patients who have FGFR2 fusions. Who have not been treated before. I cannot pronounce this drug, so I'm going to try and pronounce it. It's lirafugratinib. It's a highly effective FGFR2 inhibitor. And in the Refocus study, this was a phase 1, phase 2 trial. They looked at patients who had received prior chemotherapy, but no prior FGFR inhibitor therapy, giving them this drug. And what they essentially found was that there was an overall response rate of 46% with a median duration of response of 11 months with a median overall survival of 22.8 months. Now, when you look at it compared to pemigatinib and futibatinib, you can see the response rates, I think, would be fairly similar, but there's a higher median duration of response. And in my mind, a really good median overall survival of 22.8 months, which is less than what we saw with pemigatinib, but similar to what we saw with futibatinib. So in your mind, Dr. Shitara, how does Refocus improve clinical practice and what does it teach us?
Well, I think this is a single arm study. So again, it is not easy to compare the efficacy of this new FGFR inhibitor than previous study like futibatinib or others. But it showed a very interesting and encouraging activity. And if we have a cohort, particularly in patients who are exposed or refractory to these currently available FGFR inhibitor, the activity of this compound is more well described. And I believe such phase 1 data is already reported with this compound, but this large phase 2 study didn't include such patient. And if we remember the history of EGFR inhibitor or ALK inhibitor for EGFR mutated lung cancer or ALK fusion lung cancer, always, second generation and third generation are eventually compared with the first generation in randomized study. And if it covers the clone which are resistant to the first generation TKI or others, usually second or third generation is better even as an upfront treatment. So I hope this new FGFR TKI could be used in front line, but we need more data to confirm.
We then saw some interesting results. It was a phase 1 trial, but I found the results really interesting. Looking at an inhibitor of KRAS G12D, specifically in those patients with pancreatic advanced cancers. This was, like I said, a phase 1 study. It was a dose escalation study where they gave the inhibitor either as monotherapy or in combination with chemotherapy. The chemotherapy regimens were either GEM, nab-paclitaxel, or modified FOLFIRINOX. And when you look at the monotherapy arm, you can see a very decent overall response rate of about 37%. I thought that was a very, very interesting and also good disease control rate. And when you looked at it in combination with GEM nab-paclitaxel, it was actually well tolerated without compromising the dose intensity. And when combined with modified FOLFIRINOX, again, very decent tolerance without, again, compromising the chemotherapy dose intensity. When you're looking at it being used with either first or second line therapies, again, it was very interesting that it didn't really matter. You had an overall response rate of almost 50% with the higher dose. But again, the numbers are very, very small. When you're looking at the baseline change in the variant allele frequency, again, when you're using it in combination with chemotherapy, I thought that was, again, very nicely suppressed. So what is your impression of the results? Is this something that you think is going to potentially change clinical practice? We've seen a lot of inhibitors come into clinical practice. We've seen the FDA approve a pan-RAS inhibitor for patients with low-grade or borderline type of ovarian cancers recently. But what about here for pancreatic cancers? Do you think this will be the next big thing?
Yeah, I think this kind of KRAS inhibitor for pancreas or PDAC is quite exciting because before that, many targeted agents have failed to show its benefit. But this should be the clearly effective drug or class of agent. But first, we may have a upcoming phase 3 study of Revolution agent with RAS pan-RAS inhibitors. So any other agent like this KRAS G12D showed better outcome or some activity even in Revolution medicine agent exposed patient as same as the previous FGFR inhibitors. So that data is quite encouraging, and other KRAS G12D inhibitors show some toxicity, but this agent seems to be quite promising, and it looks feasible even with a combination. So I think this is a quite nice data, but surely we need a large study to show some PFS or OS benefit before
Absolutely.
receiving regulatory approval. And eventually, we need to show the difference with first generation like from the Revolution medicine.
If I may just go back to the VAF that we see here on the slide, do you think that the reduction in the VAF that we're seeing, the huge reduction in the VAF that we're seeing, is mainly driven by the chemotherapy component rather than the KRAS inhibitor component? Or do you think it's really the combination of the two? Because we don't actually have that data, right?
Yeah, but looking at the left side graph
This is
with response
monotherapy.
rate, monotherapy, but still not a few patients showed reduction. And
Yeah.
then we see the additional combination activity. So I think, I'm not sure whether this is called as a synergistic, but both agents are active, chemotherapy and KRAS inhibitor. And if we can combine together, I believe this is a very relevant data to support combination.
So there is a phase 3 trial that's going, which is the DAWN study, as you mentioned. Why add cetuximab here? What was
Well,
the rationale for that?
I think this is a for colorectal, right? On the lower panel is
No,
colorectal.
this is for the colorectal, and the top part is for pancreatic. So
PDAC.
they're going to be, yeah.
For PDAC, we don't need EGFR inhibitor, but colorectal, we have a high EGFR expression as well as a very strong signal through EGFR. That's why any RTK inhibitor, like a BRAF inhibitors, is because of the signal, such signal blockade increase EGFR expression and such downstream pathway through other molecules. So I think EGFR inhibitor is quite important if we target lower kinase like a KRAS.
Okay, so let's shift gears to actually colorectal cancers. We know that the standard of care in patients with BRAF mutations is actually to give encorafenib, cetuximab, and chemotherapy. We know that this is associated with a progression-free survival as well as overall survival. This year at ASCO GI, we saw the updated or the other cohort results of Breakwater, where they combined the encorafenib cetuximab combo with FOLFIRI in these patients with BRAF V600E mutation. You can see the patients were randomized to get encorafenib cetuximab FOLFIRI versus the control of FOLFIRI plus minus bevacizumab. Primary endpoint was overall response rate with key secondary endpoints of progression-free survival. In terms of overall response rate, clear-cut improvement from 39% to 64.4%. In terms of overall survival, there is a trend, but again, this is still immature, favoring the group of patients who are getting encorafenib cetuximab plus FOLFIRI. In terms of the treatment-related adverse events, it was more than 15%. I thought it was pretty similar, but you can see nausea, diarrhea, and vomiting tended to be more with the triplet combination. So do you think, Dr. Shitara, that it is clinically relevant today to look at that combination of FOLFIRI plus encorafenib plus cetuximab, and where would we place it?
Well, I think based on this study, either FOLFOX or FOLFIRI can be used when we combine with a BRAF inhibitor. But most important population should be patients who experience recurrence after perioperative or adjuvant treatment at early stage, early interval. For example, just after completion of FOLFOX, and then patient experience disease recurrence with BRAF mutation. I think this kind of FOLFIRI-based regimen is quite relevant. So that's why I think this study and cohort is still important.
But in a patient that's, say, stage 4 de novo or someone that's relapsed, say, 5-6 years later, would you prefer FOLFOX or FOLFIRI?
Well, in clinical practice in Japan, FOLFOX is clearly more preferred based on toxicity profile, particularly irinotecan induce some hair loss. I think this is very important for patients, and oxaliplatin neuropathy is also relevant for a small proportion of patients, but usually FOLFOX is preferred.
Okay. We then saw the results of the COMET study. This is another colorectal cancer study specifically for patients with MMR deficient disease. These patients were randomized to get either atezolizumab or atezolizumab plus bevacizumab plus chemotherapy, or chemotherapy plus bevacizumab. That arm of the study was actually terminated. And what you see here essentially is the question of, could you potentially use immunotherapy as a single agent in those patients with MMR deficient disease who have not received prior chemotherapy? Again, the median age was about 60 years. About 22% of patients had a BRAF V600 mutation. The majority of these patients had either right-sided or transverse colon tumors. And a lot of these, at least half of these patients had high baseline CEA levels. And what you essentially see here is that in terms of progression-free survival, and these were all MMRD patients, when you gave atezo by itself, the PFS was 5.3 months versus giving chemo plus bev plus atezo, it was 24.5 months. Dr. Shitara, were you surprised to see this big discrepancy in the PFS with single agent atezo in an MMR deficient patient?
Well, especially, historical, as a control arm with atezo, it show only 5 months in PFS, although the tail of curve is relatively good, but median PFS is very short, particularly compared with KEYNOTE-811 or checkmate study using anti-PD-1 therapy. And this atezo is a PD-L1 inhibitor, which couldn't prevent interaction between PD-L2 and PD-1 expressing effector cells. I think in some tumor type, like a general gastric cancer population, durvalumab as a PD-L1 inhibitor is still effective, but in some tumor type, some studies suggest the PD-1 inhibitor is better, and I believe this is a particularly tumor type with a high PD-L2 expression. So surely we couldn't conclude, but I think historical control, compared with historical control, PFS is not so good.
But when you look at the overall survival and the comparison between the two arms, there was absolutely no difference. So again, that was surprising for me to see such a huge. I mean, normally we do see this where we see the impact on the overall survival, but not on the PFS. But here it was the opposite in terms of
Yeah.
using that single agent immune checkpoint inhibitor. And like you said, when we compare it to the Checkmate trial, we're using dual immune checkpoint inhibitor with Nivo plus Ipi, you're actually seeing a very nice separation. So if I could ask you the question, Dr. Shitara, if you had a patient in your clinic today with an MMR deficient colorectal cancer who is chemo naive from a metastatic standpoint, MMR deficient, what would be your preferred choice? Would it be dual and immune checkpoint inhibitor therapy, pembrolizumab plus chemotherapy, or what we saw in Comet, where you're adding Bev, atezo plus chemotherapy?
As mentioned before, in gastric, we cannot use Nivo-AP, so my choice is always chemo and a checkpoint inhibitor. But in colorectal, we have nice data with the Nivo-AP, so our standard of care is Nivo-AP based on such data. And this study with atezo suggests the impact of chemotherapy, particularly to prevent progression-free survival, but they're still too small to conclude. And I believe it is very hard to approve Japanese approval based on these small studies, and this is still, not the standard of care, and we need additional studies to confirm the impact of chemotherapy, particularly doublet chemo or sequential treatment, or such approach should be tested in randomized fashion.
If I can ask the question, if you had a patient who was stage 4 de novo colorectal cancer, MMR deficient, but in impending visceral crisis, like the liver is studded with disease, would that influence your decision of dual immune checkpoint inhibitor versus adding chemotherapy, just to get a quicker response? Because that's some of the discussions we have in our MDTs.
Well, for colorectal, again, from reimbursement to approval stage, we cannot use chemo and a checkpoint inhibitor combination, unfortunately. So we don't have such question, but maybe we will test Nivo-AP first, but if patients show some progression, maybe we can immediately use chemotherapy. This is the current situation in Japan, but if you can use chemo IO combination, I think this is very hard to determine. Maybe chemotherapy should have some low, but still Nivo-AP is very, very effective and very feasible, particularly with a low dose of EP. So
Okay.
for almost all patients, my preference in practice is Nivo-AP.
And again, this is just because I've read some data recently. I think it was a Nature paper that came out last year that looked at GI tumors and the MMR deficient state and substratified them based on their TMB levels. The ones that are high TMB, higher probability of response, but the low TMBs,
Yeah,
they don't
yeah,
respond that well. So would
yeah.
that also influence your decision if it was allowed in Japan?
Yeah, I think yes, such data should be helpful. And recently, I have a patient with Lynch syndrome, young lady with a high TMB, very high TMB. No doubt, I start Nivo-AP. But if I have a very elderly patient, maturation status relatively low TMB, maybe if I have access to chemo and a checkpoint inhibitor, maybe very hard to determine because such combination should be also fit for or appropriate for such patient. But again, we need a moderator, maybe random stratification by TMB status and other biomarker in previous keynote of 177 or checkmate study should be helpful for us to guide such a stratification.
Okay. In our last abstract, this is the Foxtrot trial. I've always found the Foxtrot to be very, very interesting study because it's in all the guidelines, but nobody actually uses it. And this was this particular abstract looked at those patients RAS wild type who have either HER2 expression or HER3 expression, and to see where the benefit is in terms of adding other medications. So you can see these were patients locally advanced colorectal cancers, fit for surgery and chemo, and not obstructed. They were either getting pre-op therapy or post-op therapy. In the pre-op setting, they got either 6 weeks of FOLFOX or 6 weeks of oxaliplatin 5-FU plus panitumumab, and this is what they actually presented. And the question that they asked was, can HER2 or HER3 expression improve patient selection for neoadjuvant FOLFOX plus panitumumab and the additional impact of ARAG expression? And what essentially they found was that in patients with HER2 expression, whether high or low, very similar in terms of the numbers. And you can see in HER3 expression, again, very similar in terms of numbers. And you can see in terms of the prognostic outcome or the predictive outcome, HER2 had no association with panitumumab efficacy, hazard ratio of 1.53, looking at the DFS as well as the OS. And when you looked at HER3 expression, again, there was here associated with significant benefit from the addition of panitumumab to neoadjuvant FOLFOX therapy, but had no prognostic outcome effect on the DFS or OS. So, and then when they looked at the joint model for the ARAG and ERAG, you can see, again, there was a strong correlation between ARAG and ERAG, but no correlation between HER3 and ARAG. So again, what does this data tell you, Dr. Shitara? Because I wasn't really, for me, I found it wasn't really a practice changing in terms of what I could do in the community, but I thought it was very interesting because we do have patients that walk into our clinic with locally advanced colon tumors where the surgeon is not so interested in doing surgery up front, and you want to give them some chemo to reduce that bulk of disease. They're MMR proficient, not MMR deficient, RAS wild type. Could we use this in those specific instances? What are your thoughts, Dr. Shitara?
Well, I think still upfront surgery is a global standard of
Of
care,
course.
but I can understand there's a situation or practical reason in each institution where surgery take time to do, and then to give one cycle of chemotherapy or such neoadjuvant approach is still helpful or still good because of the UK study to support Foxtrot study itself to support such neoadjuvant approach already. And using HER2 to consider panitumumab is not conclusive based on study. And same is true for previous phase 3 study where HER2 expression didn't show large difference between EGFR inhibitor and BGF inhibitor like bevacizumab. But now we know we have a more better HER2 targeted agent like a trastuzumab or TDXD. So in future for this population, I think application of a HER2 targeted agent in clinical trial should be more and more important. For HER3, there's a different story. Some studies showed high HER3 expression as well as each ligand is associated with the resistance, but this study didn't show such trend. So I think this is again not conclusive, and we couldn't change practice.
Well, thank you very much, Dr. Shitara. This has been an awesome 1 hour conversation where you've taken us through upper GI, middle GI, and lower GI. I know I've learned a lot, and I'm sure everyone out there has had a tremendous time. Thank you so much for coming on board and sharing your experiences and your thoughts. I know I will be emailing him quite a bit to get consultations for my patients because at the end of the day, we're all trying to help our patients. So thank you so much for today. Thank you.
Thank you.